Assalamu alaikum. We will start one of the most important and practical session, which is concerning one of the most important items, which is tuberculosis. This session we will start with Dr. Kenza Binani. She will give talk about the New York Declaration on the fight against tuberculosis. Dr. Kenza.
Good morning, everyone, ladies and gentlemen. First, I would like to present my thank you to all organizers to invite me and to invite WHO to take part of this big event, big conference. It is my pleasure and my honor to get you this presentation to talk about TB. First, I will present TB situation at the global level and in our region. And I will give you a talk about many commitments we have seen during the last 2 years at high level, including UNGA political declaration. So, if you allow me, we start. Yes, what is the situation at global level? So, globally, we have seen progress. To date, with 58 million lives saved between 2000 and 2018, the mortality rate fell by 38% in the same period. However, there is an estimate number of 10 million people fell in with TB in 2018, according to the last global TB report, while 7 million of them has been diagnosed and have access to TB care and services, up from 7.4 million in 2017, and 3 million remains underdiagnosed and not reported to national TB programs. Yes, these graphs show the trend of TB incidence in different regions. In green, TB incidence, and in black line show TB notification. In general, there is a trend of decreasing in TB incidence in all regions. The fastest regional decline since 2000 has been in Europe, with 5% decrease per year. And incidence has also fallen relatively fast in Africa, with 8% per year. And the cumulative reduction in these two regions were 15% and 11% respectively, putting them on track to achieve 2020 milestone. Since 2010, annual declines in incidence has been much slower in our region, in the Eastern Mediterranean region, with less than 1% per year. In addition to South Asia, East Asia, 2.2 per year, and the Western Pacific, 1.6 per year. That means these countries will not be, probably they will not be on track to reach 2020 milestone. As you know, TB remains the top infectious killer worldwide, with 1.5 million people died from TB in 2018, including 250,000 people living with HIV. For drug-resistant TB, it remains a public health crisis, and we are talking about 500,000 people who had drug-resistant TB in 2018, and only 1 in 3 people have access to drug-resistant TB treatment. What about TB preventive treatment? As you know, WHO recommended preventive treatment for people living with HIV and all contacts living in households contacts with TB, but we have also something like 50% of persons living with HIV who have access to TB preventive treatment, and not more than 350,000 children under 5 of age who have access to preventive therapy, which is less than the 4 million estimated to be eligible for preventive therapy. When we talk about funding, the funding request for a full response to the global TB epidemic in low and middle-income countries is estimated at 10 billion in 2019, excluding the research and development. 6.8 billion was available for TB prevention, diagnosis, and treatment in 2018, and we have a gap which is about 3.3 billion. For research and development, at least we have 1.2 billion per year needed to accelerate the development of new tools and treatments. What about TB situation in our region? Yes, this graph shows the TB incidence of the Eastern Mediterranean region, which was 150 per 100,000 population in 2018, which represent 8% of global TB incidence. In addition to that, for mortality, it was about 77,000 people who died from TB, and that represents 7% of global mortality with TB. We have seen many variations. When we talk about TB incidence in our region, we have countries with less than 10, with incidence less than 10 per 100,000 populations, but majority of countries in our region have TB incidence between 10 and 100 per 100,000 populations. And we have 4 countries, Afghanistan, Djibouti, Pakistan, and Somalia. These countries are considered as high burden countries with the TB, which means the incidence exceed 100 per 100,000 population. Indeed, 79% of TB cases notified in our region are in Pakistan, and 31% remaining cases are in other countries, with 9% in Afghanistan and 5% in Somalia. There is an increase in case notification in our region during the last 10 years. However, notification gap remain high with 35% gaps, yes, and when, yes, many countries in our region reached more than 85% for treatment coverage rate. However, 5 countries are responsible for around 93% of missed cases with TB in our region: Afghanistan, Iraq, Pakistan, Somalia, and Sudan. When it comes to drug-resistant TB, 5 countries in our region are representing 97% of estimated drug-resistant TB in our region. And 38,000 MDR TB cases estimated during 2018, we reached only 50% of patients with drug-resistant TB who were confirmed with MDR, and only 11% of them started treatment. Among the 6 WHO regions, the highest treatment success rates in 2017 were in the Eastern Mediterranean region, and this graph shows that for new and relapsed TB cases registered during 2017, the treatment success rate was high with 91%. It was 75% for those previously treated for TB, 74% for HIV positive TB patients, and for MDR TB patients, the treatment success rate was 65%. Yes, we have many variations at global and in our region when we talk about TB incidence. And TB incidence rate is slowly declining and not more than 2% per year globally. And the main questions that we should ask ourselves, there is problems with access to health services, problem with inequities, poverty, malnutrition, comorbidities, HIV, diabetes, drug resistance, infection pool of 1.7 billion people, global aging, air pollution, urban area, crowded area. How can we, oh, sorry. If we make our business as usual, we cannot hope to reach ending TB on 2030. And how we should do to make the business as the business in usual, with universal access to care, with introducing innovative actions, post-exposure vaccines, and safe TB treatment to make sure that we will be on the right way to reach ending TB by 2030. Yes, of course, in the past 2 years, tuberculosis has seen unprecedented focus and commitment with the first WHO Global Ministerial Conference on ending TB in 2017, which happened in Moscow, Russian Federation, under the slogan, "We need to end TB in SDGs area, a multi-sectoral response." And in September 2018, the United Nations held its first ever high-level meeting on tuberculosis, resulting in a political declaration agreed by all UN member states, and in which existing commitment to SDGs and WHO anti-TB strategy were affirmed. The first United Nations General Assembly high-level meeting on TB took place to accelerate effort in ending TB and produce a political declaration with ambitious additional targets aligned with SDGs and anti-TB strategy targets. The political declaration set numerical targets to be met by 2020 that included 40 million people with TB to reach with care and TB treatment, and at least 30 million people to reach with TB prevention treatment. And the political declaration reaffirms commitment to mobilize sufficient and sustainable financing for universal access of quality prevention, diagnosis, treatment, and care of tuberculosis, and to increase overall global investment to $2 billion to overcome the global public health crisis of multi-drug resistance, to improve policies and systems under universal health coverage, to enable multi-sectoral collaboration, to promote ending stigma with special attention to the poor, vulnerable, and communities especially at risk, to advance research and innovation. And it was a request to DG of WHO to continue developing multi-sectoral accountability framework and to ensure that implementation will be no later than 2019. And the last point of this political declaration included the request to provide a progress report in 2020 on global and national progress, and progress in implementation of the present declaration toward agreed TB goals at national, regional, and global levels, which will serve to inform preparation for a comprehensive review by health of states and government at high-level meeting in 2023. What about translating commitment for accelerating action to end TB, what we did in our region? 2019, WHO was involved to advocate through a high-level mission to Pakistan to advocate for acceleration of ending TB response, as Pakistan is dealing with around 70% of burden of our region. To align national strategic plan to high-level meeting on TB targets and to strengthen multi-sectoral actions and accountability. We provided country support in the area of MDR TB through RGL submissions and a regional workshop to make more preparation for transition toward the new drug-resistant TB policies. And we supported high-burden countries in our region through program reviews, guidelines development, implementation, and procurement, in addition to our support to countries in complex emergency. In addition to that, there are many developments during this year, including new recommendations on drug-resistant TB treatment, update on latent TB infection. There is a new guidelines on tuberculosis infection prevention and control, new roadmaps for engaging private sector, a roadmap for ending TB in children and adolescents, and there is a user guide for people-centered framework for tuberculosis program planning and prioritization. What is the future and what is the perspective for the new coming years? Yes, WHO will continue the effort to reach the 3 billion, 1 billion more people benefiting from universal health coverage. And the 1 billion more people better protected from health emergencies, 1 billion more people enjoying better health and well-being. Yes, ending TB should be associated with more attention to social determinants and risk factors, including malnutrition, tobacco, alcohol use, HIV, comorbidities, including HIV and diabetes. WHO, yes, of course, for the multi-sectoral collaboration, right now we have a multi-sectoral accountability framework, and it was included as a request for DG of WHO to have the multi-sectoral accountability framework to be ready before end of 2019. We have now to support member states for adaptation, for its adaptation and use at country level with development of all documents and monitoring use of this framework. What it is, yes, this WHO will provide a progress report in 2020 on global and national progress and progress in implementation of the present declaration, which will serve to inform preparation of a comprehensive review by health members, by heads of state and governments, and at high-level meeting in 2023. So it is my last slide to tell you that it is time to accelerate and to lose momentum. It is time for ending TB, and would like to thank you for your attention.
Thanks a lot, Dr. Kenza Pinani. The presentation is open for discussion. Okay. Okay, Dr. Ayman.
Mentioned this in your presentation. Yes. Post-exposure vaccination.
Thank you for questions. Indeed, yes. If we want to make the business differently and to make to think out the box. The idea there is modelization. If we make the work as we did and we continue in the same, we cannot bring changes, and we will not be. We are not sure to reach our target for ending TB by 2030. Yes. If we take innovative actions by introducing new vaccines, it is not the case at the time we are discussing now. But if there is a new vaccines post-exposure, if we can make a difference with TB preventive treatment post-exposure, and for this we talk about latent TB infections, we can bring many differences in terms of reducing TB incidence and reaching the target by 2030.
Okay, thank you very much, Dr. Kenza. And now it's my pleasure to introduce دكتور وجدي أمين. دكتور وجدي مدير إدارة الأمراض الصدرية في وزارة الصحة. He will speak about our dream, elimination of tuberculosis in Egypt by 2030. تفضل دكتور وجدي.
بسم الله الرحمن الرحيم. طبعا كل الشكر والتقدير لأساتذتي الأفاضل على الدعوة الكريمة. الأستاذ الدكتور طارق صفوت رئيس المؤتمر، الأستاذ الدكتور أشرف حاتم وزير الصحة الأسبق، وطبعا متشكرين جدا على المقدمة، وطبعا شير بيرسون مع الأستاذ الدكتور مصطفى الشاذلي وجميع الحضور. هكلم حضراتكم عن الرود ماب اوف TB elimination in Egypt 2030. As Dr. Kenza mentioned, with the WHO global strategy, tuberculosis is a communicable disease that is major cause of ill health, one of the top causes of death worldwide and leading cause of death from single infection agent. It's caused by Bacillus mycobacterium tuberculosis, and it is typically affect the lung and called pulmonary tuberculosis, and maybe affect other sites and called extrapulmonary tuberculosis. And 1/4 of world population is infected with mycobacterium tuberculosis, and thus at risk of developing TB disease. Tuberculosis is old disease, and it is one of the famous people who died from tuberculosis in Egypt is Tutankhamun. And Edward Smith Papyrus mentioned tuberculosis, which is discovered by Raffer in 1910, and reported the presence of tuberculosis in Egypt. Tuberculosis control started in Egypt actually in 1926 by establishment of a sanatorium in Helwan, and in that time it is headed by Dr. René, which is from Switzerland, and it is used to isolate the patient from the population to prevent the infection, and he's used artificial pneumothorax to treat tuberculosis patient. Then, when the Ministry of Health was established in 1936, the first hospital was established in Abbasiyah, which contained 1,000 beds for tuberculosis patients. Then this strategy started in Egypt in 1996 and expanded all over the country to 2000. And we will talk about the incidence of tuberculosis. Incidence means the estimated number of new and relapsed tuberculosis cases arising in given year, expressed as the rate per 100,000 population. All forms of TB are included, including cases in people living with HIV. This is the TB estimated burden in Egypt from 2015 to 2018. In 2018, we was 15 cases per 100,000 population, and as Dr. Kenza mentioned, we want to decrease or decrease our incidence in 2020 by 20% based on 2015. And we already achieved this goal, and now our incidence is 12 cases per 100,000 population. Our case detection is 68%. If you want to stop TB from Egypt or end TB from Egypt, this is our forecasting. From 1990, we achieved the Millennium Development Goal in 2015, and our incidence declined by more than 50%. In 2015, it was 15 cases. And we want to achieve the goal in 2025 to decrease the incidence of tuberculosis cases by 50% based on 2015, and in 2030 to achieve 80% decline in the TB incidence based on 2015. And this is the curve for project acceleration of TB incidence decline in target level, which is discussed by Dr. Kenzie. And she mentioned for the introduction of new vaccine, and it may be started in 2025. For case notification of Egypt, we notified in 2018 8,448 cases. Among them, the total new and relapse cases was 8,280 cases. 73% tested with rapid diagnostic at the time of diagnosis, and 38% screened for HIV and known the HIV status. 54% was pulmonary tuberculosis, and the remaining cases was extra pulmonary tuberculosis, and 83% was confirmed among pulmonary cases. This is the 6 distribution cases, and as you see, according to the agent 6, there is equality in the TB in the childhood period from 0 to 15 years, and then the ratio between men and female 2 to 1 in the reproductive group. We also make strengthening in the surveillance system, and we establish a new surveillance system, web-based surveillance in collaboration with the Information Center in the Ministry of Health. And now every unit or every TB unit can log in this website by username and password, and they can enter to this website and start to enter the data of the TB patient as the data mentioned in the TB card, and we can extract the reports from this website easily according to the period we need. And this is the report. We can show the report like this. If we need to show any governorate, we can see any TBMU in the governorate, and we can extract the data in Excel sheet, then make data analysis. We update our guideline according to the last updates in tuberculosis control guidelines of WHO, and we forced to increase our capacity of diagnosis of tuberculosis, as the sputum smear microscopy is the old method to discover diagnosis. It developed more than 100 years. This technique requires the examination of sputum sample using microscope to determine the presence of bacteria, but the sensitivity is very low. There is many cases false positive, and it not differentiate between Mycobacterium tuberculosis and Mycobacterium other than tuberculosis. So we introduce many new methods like culture-based methods. We introduce Levenstein-Jensen as a solid culture and liquid culture, and now we have 4 centers detect tuberculosis by liquid culture. We also introduce the rapid molecular test. It is the only rapid test for diagnosis of TB currently recommended by WHO. It can provide the result within 2 hours. In 2010, it is recommended for diagnosis of pulmonary tuberculosis in adults. In 2013, it is recommended to use in children and diagnose specific forms of extrapulmonary tuberculosis, and it is much better accuracy than sputum smear microscopy. And now we have 19 machines in 18 governorate, and after 1 month, we will have 29 machines, inshallah, and it will cover all governorates. Line probe assay also, it is approved for direct testing of smear positive specimen, and it is detect the sensitivity or the drugs resistant for tuberculosis will be available during 48 to 72 hours, and it will detect the resistance of isoniazid and rifampicin, and it will be available in our central lab during the next month, inshallah. For the chest radiography and its use in the TB screening, as chest radiography or chest X-ray is an important tool for triaging and screening of pulmonary tuberculosis, and it's also useful in aid diagnosis when pulmonary TB cannot be confirmed bacteriologically. So we use chest X-ray now for screening of outreach area, and we have 2 cars, this is our mobile car, and we use it in screening of slum area, in the prisoners, in the hostels, in some factories. So we use it in many places now. And also we established the diagnosis for extrapulmonary tuberculosis, and it is the most TB test to rely on sputum as the sample, but this will not work for TB outside the lung, so it is performed due to by clinical suspicion, sample taken from the suspected site of the disease. The options to diagnose extrapulmonary may be by smear, likely to be negative, gene expert may be negative, and if the specimen is available from the tissue biopsy, gastric content, pus, cerebrospinal fluid, and urine, it may be tested by gene expert. We can use the diagnosis of extrapulmonary by culture. It is helpful and take 2 to 3 weeks by liquid culture. And the most diagnostic test which is confirms the diagnosis of extrapulmonary is the biopsy. It is very helpful. And we make our algorithm for the diagnosis of TB presumptive, and it is included in our guidelines. We update our TB treatment by CAT1 and CAT2. As you know, the new cases can take 6 months treatment. The first or intensive phase, 4 drugs used, 2 months for INH, rifampicin, pyrazinamide, and ethambutol. And for continuation phase, we're using INH and rifampicin. CAT2 is now will be depends on the DST or drug susceptibility testing of the patient, and it will be phased out, inshallah. Integration of TB and HIV services. HIV testing should be routinely offered to all patients with presumptive TB, and this who have been diagnosed with tuberculosis. Persons also living with HIV should be screened for TB by using the clinical algorithm, and gene expert is preferred to diagnose TB in HIV test. Antiretroviral therapy and routine cotrimoxazole preventive therapy should be initiated among all TB patients living with HIV, regardless of their CD4 cell count. And this is our data started from 2008, number of TB patients and how many cases tested for HIV and how many cases detected as TB and HIV infection or co-infection. Also, we make proper management for childhood tuberculosis, and we update our guideline according to the last guideline of WHO, and we introduce the new formula of pediatric treatment, and we're using now this formula by corrected doses, dissolvable in water, and tested food. Already the doses of tuberculosis or anti-TB drugs is different from adult to children. So rifampicin used by 15 milligram per kg per day, azonazide used by 10 milligram per kg per day, pyrazinamide used by 35 milligram per kg per day, and if we need to use ethambutol, it is used by 20 milligram per kg per day, and the children 25 kilogram or above can change to adult dose. And this is the doses of the childhood or pediatric formula, and we give it according to the weight band. The children weighted from 4 to 7 kilogram, we can use 1 tablet only. Weighted from 8 to 11, we can use 2 tablets. From 12 to 15 kilogram, we can use 3 tablets. And from 16 to 24, we can use 4 tablets. And above 25, we can shift to the adult preparation. We also include the management of latent TB infection in our guideline, and we start to treat all latent TB infection in risk population like HIV, children under 5, patient initiating anti-tumor necrosis factor, patient receiving dialysis, and patient preparing for organ or hematological transplant, and patient with silicosis. This patient is tested by tuberculin skin test or by quantiferon, and the positive patient can given isoniazid for 6 months or rifampicin plus isoniazid for 3 months. For drug-resistant tuberculosis, we also aligned with the new guidelines. Drug-resistant tuberculosis started in Egypt in 2006, and in last year, there is 90% of new cases tested for rifampicin resistant, and 88% of previously treated cases tested also for rifampicin resistant, and the patient started on treatment was 80 cases. There is no XDR cases in Egypt. And the cases tested for second line is 38, and there is no cases detected as XDR. The success treatment in 2016 was 66%. Since the number of cases started or enrolled in the drug-resistant tuberculosis treatment in Egypt from 2006, it reaches 937 cases by the end of 2018. According to the guideline of WHO, there is many changes in the guideline, but now we will start to use this table to treat the MDR cases, which start by group 1, include levofloxacin or moxifloxacin, betacholine, and linezolid. Then 2 medicines from group 2, clofazimine and cycloserine. And if you want to add any treatment or replace any drugs from group 1 or group 2, we can use group C as isambitol, delamanide, pyrazinamide, amikacin, isoniazid, and para-aminosalicylic acid. But I think we're waiting for another change, inshallah, recently in MDR guideline. And we also will implement the new shorter regimen, which is composed of kanamycin or amikacin now for 4 to 6 months, and moxifloxacin, brosionamide, clofazimine, pyrazinamide, high dose of INH, and ethambutol, then continuation phase for 5 months with moxifloxacin, clofazimine, pyrazinamide, and ethambutol. And this is the algorithm of how to use or select which regimen for the patient. So the shorter regimen can be used for the patient after exclusion of many situations, like he must be not exposed to second line for more than 1 month. He can tolerance to more than 1 medicine for shorter TB regimen. It is not pregnant. There is no extrapulmonary disease. At least 1 medicine and the shorter MDR regimen. If it is not available, we cannot use the shorter regimen. And also it's confirmed resistant or suspected ineffectiveness to a medicine in the shorter MDR TB regimen. If the patient not made this selection, so we will shift to the one of the longer regimen as conventional regimen or the injection-free regimen. And also we included in updated guidelines isoniazid-resistant TB, as isoniazid is one of the most important first-line medicine for the treatment of MDR because it is used in the active tuberculosis treatment and latent TB infection, and the percent of resistant worldwide is 8%. So we will use this regimen as WHO recommendation in rifampicin susceptible and isoniazid-resistant tuberculosis treatment with rifampicin, isambitol, pyrazinamide, and levofloxacin recommended for 6 months. And this is our website in the curative sector website and the Ministry of Health website. And we, inshallah, wish to unite together to end tuberculosis from Egypt, inshallah, and thank you.
Thanks a lot, Dr. Wagdi, for your effort in elimination of tuberculosis. And now we will ask Professor Ayman Salim to give us a talk, Professor, about the recent advance in diagnosis of tuberculosis. احنا اوكي اخر السيشن احنا دكتور اخر اوكي the last at the end of the session because we are out of time. Okay, عشان الصلاة كمان. Okay, now Professor Ayman Salim, Professor of Chest Diseases and Tuberculosis, Cairo University, and he is the chairman of Chest Department at Cairo University. Professor Ayman.
Thank you, Chairperson. Thank you for inviting me to this wonderful Congress. It's my pleasure to be here. I'm going to speak to you about, in the next 20 minutes or so, about updating or recent advances in diagnosis of tuberculosis. It's basically all how to reach a diagnosis. For now, the WHO and the TB strategy, it's insisting on reduction of new incidence of new cases to 90%. Hardly we could reach 100%, so the target is 90%, as Dr. Kenza just mentioned, and 90% reduction of TB death rates by 2035. How could we reach this? This is achieved by detection of new cases, and then we apply the proper treatment and targeting latent tuberculosis infection. This is how we should reach the target of NDTB strategy, by detection of new cases, and much more important than detection of new cases, the detection, the situation of these new cases, meaning drug sensitivity to detecting the resistance pattern of the organism and its drug sensitivity. Typically, we diagnose tuberculosis using sputum culture, sputum direct smear and the culture. Tuberculin test duty in diagnosis is not so enriching diagnosis, just reaching infection. X-ray is not used for a long time, used to be not having a definite role in diagnosis of new cases. It has a role on diagnosis of establishment of extension of the disease, meaning unilateral, bilateral, minimal, or far advanced, or so. Again, genetic probing like DNA, PCR, this is the typical how we should diagnose tuberculosis for a long time. We stress on radiology now. If you speak about far advanced tuberculosis, then it's easy to diagnose, but what's important to reach NDTB strategy is to target the minimal cases of tuberculosis, meaning it's not apparent, and of course with sputum test. If we have if we have the right way of diagnosis, usually we speak about clinical presentation, radiological presentation, that what makes a patient is suspect. So the patient is suspected to have tuberculosis, that means it may or may not have tuberculosis. The concept to reach NDTB strategy is much more than a suspected case, it's a presumptive case. So they assume that the case is tuberculous and they start the management early. And this is already mentioned in the National Anti-Tuberculosis Control Program in Egypt, and this is already taken from the WHO strategy. So this is the difference between a suspect and a presumptive TB case. So there is no more suspect when we come to a case of tuberculosis. We assume this is tuberculous, and the range of clinical presentation is wide, so it's not just a cough. Now we can diagnose with much more wide range of clinical data, cough, fever, weight loss, hemoptysis, and any abnormality of chest X-ray. That was not mentioned in the case detection previously. But now, if you are having any abnormality of chest X-ray, even minimal changes, and some clinical data, then we assume the case is tuberculous, and again the comorbid factors and the contact is having a wide range. So we have a much more broad clinical data and much more clinical suspicions when it comes to contact. So the case is supposed to be tuberculous until proved otherwise. So we have to prove, and this kind of proving or disproving a case of tuberculosis, it should take less than 5 days. Less than 5 days, and we detect the case is tuberculous or not. So this is the newly accepted line for the management of presumptive TB. Sputum for acid-fast bacilli is on the top of the list. Then culture is requested, but we are not guided to initial treatment, just maybe later on after 6 weeks. Nucleic acid probe PCR, but it takes a longer time. The important line now is to apply the rapid molecular test known as GeneXpert. Line probe assay is important, but it is basically for drug resistance, so MADR and XDR resistance. The drug resistance pattern now is done basically for rifampicin from day one of diagnosing the case using the GeneXpert. So what is the GeneXpert? GeneXpert is detecting the sequence of the DNA in the mycobacterial nucleus. So there is no need to start to wait for building up the whole nucleic acid of the mycobacteria to tell this is tuberculosis. By stressing on specific segments of the DNA molecules, now we can tell that this is the human type of the mycobacteria, and even more, we can detect if this mycobacteria is sensitive to rifampicin or resistant to rifampicin. And importantly, it diagnoses the case as a human type of mycobacteria, not mycobacteria other than tuberculosis. It can use a raw sputum material. It's not a culture, and it's an automated test. It takes 2 hours only for the test to be done, and 2 days for the report to be available. 1 day for delivery of the sample and 1 day for collecting the report, and the processing time is 2 hours. Just the patient is asked to give the sample in one container, and this container is just put in this box where the processing, where it is settled for 15 minutes, and then it is put inside the machine. Just wait for 2 hours, and you know if the mycobacteria is human type or not, and if rifampicin is sensitive or resistant. So this is how we should manage within 5 days what we call the rapid diagnosis of TB. The patient is supposed to be tuberculous because of several clinical presentation, X-ray suspicious, and we apply the GeneXpert. So we may have a case as not having tuberculosis, or rifampicin susceptible, or rifampicin resistant. This is from day 0 of diagnosis, or let's speak about day 1 diagnosis. Much more important to how we get in reaching diagnosis, much more important reaching diagnosis, how we get the samples. In the old days, we used to get morning sample for 3 successive days. Now the 3 samples are obtained within maybe like 12 or 24 hours. The sample one, immediately, if you suspect the patient is having tuberculosis, so you send him to the lab where he gives the first sample immediately on the spot. And he is collecting 1 more box to give the morning sample in the next day. And by the time he's delivering the second sample, he is giving the third sample. And we obtain a report of 3 samples after just 12 hours, maybe 24 hours, the patient is having sputum positive or negative for mycobacteria. And this is based on a well-known information. 10 years ago, we know that collection of 2 samples at the same day, not just every other day, every next day, at the same day, this is equivalent to diagnostic accuracy of the conventional method, 3 morning samples. So this cuts the time maybe like a couple of days, and this is important to reach the NDTB strategies. So this is the flow chart of how we should go in the case. A direct smear for 3 samples for acid-fast bacilli, you get either it's negative or positive. 3 positive samples, it means this is the case of tuberculosis. Maybe 2 samples, 3 negative samples, it means it does not mean that this is 3 samples, 3 negative samples does not mean that this is not a case of tuberculosis and you have to do much more effort to exclude the case as tuberculosis. This is again how we reach NDTB strategy. And even 1 positive sample is not conclusive as tuberculosis. Patient with 1 positive sample out of 3 should be doing more effort, like 1 X-ray to be interpreted by a specialist and designated as tuberculosis, or you may repeat the smear once more and you get the sample number 4 to prove or disprove is tuberculosis, or you may much better to resort to the GeneXpert. So the GeneXpert is established now as an integral part in the management to diagnose new case of tuberculosis. GeneXpert, we need it for all negative cases, if the patient is having 3 negative samples and still the clinician is suspecting tuberculosis based on clinical and radiological pattern, the gene expert is a must. Dr. Wagdi just mentioned that gene expert now is diagnosing 73% of the cases in last year, maybe, of the new cases. The number was 10% on cases maybe a few years ago. Now the gene expert is an integral part in the diagnosis of human type mycobacteria. If the case is negative, after if the case is negative after sample number 4, we have to do the gene expert to prove or disprove. Only after gene expert we can tell the patient is negative case of tuberculosis. That's what we call the same day diagnosis. The same day diagnosis is applied for one smear positive. One smear positive, this supports you to ask for gene expert, just to be sure that beyond doubt we are treating a case of tuberculosis. This is the diagnosis of mycobacteria. The direct smear is not, it's okay to diagnose it for heavily infected patients, but sensitivity is not high, so maybe that's why we need gene expert. Culture is done on the day number 1, but we don't use it for diagnosis or guiding the pattern of the drugs used. Drug resistance should be looked for all patients from the first day with the initial mycobacteria sample, and that's the role of gene expert. Drug susceptibility is used 3 months later. So the basic advantage of gene expert is it's only one specimen is needed. There is no need for one more sample. This is enough. It's very specific to the human type mycobacteria. It needs a couple of hours, and it can use several tissue and several body fluids, CSF, any aspirate, tissue biopsy. There is no risk of cross-infection, cross-contamination of the sample, or human error, and it has some limitations. Just it does not monitor if the mycobacteria is living or dead, like the PCR. It's semi-quantitative. Sometimes with some technical errors, you may need a second specimen. However, this is very rare in practice. And thank you for your attention and attendance.
Thank you very much, Professor Ayman. Now we'll have our rising star, Dr. Sabah Ahmed, and she will speak about tuberculosis in women. Is there any difference between tuberculosis in women and tuberculosis in men? في فرق بين الرجاله والستات؟
طبعا
غير الجينات يورينري يعني.
اكيد في فرق، هو على طول في فرق بين الرجاله والستات. خليها بقى الله يرضى عنك. ماشي. بسم الله الرحمن الرحيم. في البدايه احب اشكر اساتذتي استاذ دكتور اشرف حاتم واستاذ دكتور مصطفى الشاذلي واستاذ دكتور احمد الحلفاوي على الدعوه للمشاركه في المؤتمر، وبهنيهم على النجاح الهائل للمؤتمر. بصراحه يعني حاجه غير مسبوقه، وعدد اجانب كتير قوي استفدنا منهم شغل وافكار للشغل كتير قوي. ان شاء الله هتكلم عن التوبركلوزس in women. Tuberculosis is one of the contiguous airborne diseases globally. It is a great cause of death in people living with HIV. Men are more diagnosed with TB. Number of cases diagnosed في tuberculosis أكتر في الميلز, but TB had more severe consequences in the females, especially على on the child mortality. This chart shows the TB incidence and the case notification aggregated by age and sex. As you see, the green area represents the male portion and the red area represents the female portion. The green is more than the red, and this means that the number of cases notified from males is more than female. Why this excess notification among cases more in males? There are many factors. The first of them increase the prevalence of risk factor in men, especially smoking and alcohol use, which decreases systemic and local lung immunity. Also, there are some barriers, including socioeconomic and cultural barriers that prevent women from seeking medical care and presenting for diagnosis. Also, iron deficiency anemia in female during a childbearing period represent a protective mechanism against tuberculosis, because iron is an important substrate for survival and proliferation of Mycobacterium TB bacilli. Also, we have an option from God, which is estrogen hormone. Estrogen prevents tuberculosis by some mechanisms. The most important of them, activation of macrophage, which was important cell in protection and the cellular immunity against tuberculosis. Also, estrogen increases interferon gamma secretion, which is an important cytokine used in the immunity against tuberculosis, secreted by natural killer T cells. In my talk, I will cover the global burden of tuberculosis in women, impact of TB on the maternal health, effect of pregnancy على course of tuberculosis, infant outcomes during pregnancy, TB diagnosis and treatment in women, especially in the special situation. TB is one of the top 5 killers among women in a childbearing period. Globally, 700,000 women die from tuberculosis every year. Tuberculosis kills more women than all causes of maternal mortality combined. TB progressed more quickly in women and had more severe consequences in women than in male. Women account for 70% of HIV-infected adults in Africa, and this increase in number of cases in women recently due to increase in incidence of HIV-infected cases. This chart shows the number of TB deaths among women disaggregated by WHO, region, and HIV. It revealed that 90% of HIV-associated deaths are among women were in Africa. What about the impact of TB on the maternal health? I will discuss 3 issues: the female genital tuberculosis, TB in pregnant women, and the infant outcomes in tuberculosis patient during pregnancy. Genital tuberculosis, one of the most common extrapulmonary forms of tuberculosis. Before the HIV epidemic, 15% of new cases of TB were extrapulmonary. 30% of them were urogenital TB, which means that it is a common form of extrapulmonary TB. It is described as a disease of young age. 90% of them present between 20 to 40 years. The common sites are the fallopian tube, followed by the endometrium, then the vulva and the vagina. The mode of spread, mainly hematogenous, then peritoneal spread. Pregnancy after genitourinary tuberculosis, very difficult because of the adhesion and the fallopian tube obstruction. Even in vitro fertilization may fail. What about the TB in pregnant women? The burden of active TB among pregnancy, active TB is much more common during pregnancy than non-pregnant female. In high burden countries, more than 60 cases per 100,000 population per year. In low burden countries, less than 20 cases per 100 population per year. The rate of active tuberculosis among pregnant females range from 0.7 to 8% among HIV-infected females in high-burden countries, and is high as 11% in tuberculous skin test positive cases. So tuberculous skin test positivity should be considered seriously in pregnant women with HIV. Latent tuberculosis prevalence doesn't show difference in between pregnant and non-pregnant women and the other general population. There is an important question. Does pregnancy affect the course of tuberculosis? Yes, pregnancy affects the course of tuberculosis. Pregnancy suppresses T helper 1 cytokines, such as interferon gamma and interleukin 12, and this may mask symptoms of tuberculosis and increases susceptibility to develop active disease and reactivation of latent TB. Also, pregnancy regulate natural killer cell cytotoxicity, so decrease the cell-mediated immunity against tuberculosis. After delivery, this suppression to the T helper 1 lymphocyte is reversed, causing exacerbation of the TB symptom, mimicking immune reconstitution syndrome occurring in HIV patient after receiving antiretroviral therapy. Also, postpartum, the risk of developing tuberculosis is twice than the non-pregnant woman. After this, is it important to screen pregnant women for active and latent tuberculosis? Is every pregnant woman should be screened for this? The answer is sure yes. Why we should screen pregnant women for TB active and latent form? Active tuberculosis should be screened in pregnant women because pregnancy accelerates the onset of TB and convert the latent TB to active disease. Also, pregnancy symptom may mask TB symptom because some of the symptoms of pregnancy mimicking some symptoms of tuberculosis. TB increases mortality during pregnancy, so we should screen for tuberculosis in pregnant women. TB increases the risk of complication, whether on the mother or on the fetus. WHO recommends screening for symptom of cough of any duration, fever, night sweat, loss of weight, and in pregnant females, and the absence of these symptoms carry negative predictive value of 90 to 97%. CDC, Center for Disease Control and Prevention, recommend shielded chest radiograph, which have a minimal risk on the fetus for females with a recent contact of TB case. If there is any abnormality in the radiology, sputum sample should be submitted for microscopy. What about latent? The problem with latent TB that the tools we use for diagnosis of latent TBs, such as tuberculin skin test and the interferon gamma release assay, does not differentiate between latent and active tuberculosis. And the pregnant women with HIV and the latent TB are more likely to progress to active TB. So it is important to screen latent TB for the presence. It is important to screen pregnant women for the presence of latent tuberculosis and for HIV. CDC recommend screening in low burden countries للhigh risk women. Pregnancy per se not high risk, but contact to MDR case or HIV or chemotherapy or any immune suppression makes a woman at a high risk for latent TB conversion to active tuberculosis. In high burden countries, latent TB screening is not routinely recommended. So tuberculin skin test is screening for is useful for screening in HIV infected patient who most likely benefit from INH preventive therapy. CDC recommend IGRA to be used in place of tuberculin skin test because of the BCG vaccination and the cross-reaction with the tuberculin skin test. But WHO does not recommend use of IGRA for LTBI screening. After the effect of pregnancy on the woman, we will discuss the infant outcome during pregnancy. We have three important outcomes for the infant. The first of them, congenital tuberculosis. Tuberculosis can be transmitted from the mother to the fetus by many different routes. Hematogenous spread during pregnancy, aspiration of the amniotic fluid during delivery, or respiratory droplet postpartum. Congenital TB may be subclinical with many range of birth defect. Also, there are some complications and infant mortality, including intrauterine growth retardation, low birth weight, prematurity, fetal deaths, and the infant with HIV positive woman more likely to die in the first year of life because of tuberculosis and HIV infection. What about the diagnosis of tuberculosis in women? The first step in diagnosis is to suspect a case of TB. Suspicion will be for pulmonary tuberculosis from the symptom, including cough of 2 weeks or more, fever, night sweat, breathlessness, loss of appetite, loss of weight, history of contact. As you see, all these symptoms are non-specific symptoms, and most of them can occur with pregnancy apart from contact with a known case of tuberculosis. Physical signs are non-specific and doesn't give an idea to the diagnosis. After clinical evaluation, we should register the case of tuberculosis in the registry done for TB. And then we request sputum for acid-fast bacilli. We should do 3 or at least 2 samples, as our Professor Ayman Salim said. If these 3 samples are positive, this is a sure case of tuberculosis and we should initiate treatment. If 2 samples are positive, also this is a sure case of tuberculosis and we should initiate treatment. If 1 sample is positive, this may be a false positive case. So we should repeat sputum microscopy, or if the clinical suspicion is high and the patient is serious, we can start on the clinical judgment anti-tuberculous treatment. If the 3 samples are negative, we should follow the protocol of smear negative pulmonary tuberculosis. Then we need some cultures if the smear for acid-fast bacilli are negative, because the culture are more sensitive and require a low number of bacteria, about 10 to 100 mycobacteria per milli. Time it takes 4 to 8 weeks before the results are known. Indication of the culture, mainly extrapulmonary tuberculosis. We can send body fluids and tissues for culture. Smear negative tuberculosis, HIV infected cases because of the high incidence of MDR. Also, we can use the culture to differentiate mycobacteria from non-tuberculous mycobacteria. Tuberculous from non-tuberculous. We have a liquid culture media. The previous one was a solid culture media, Levenstein-Jensen medium. This is a liquid culture media, the Bactic Magid 960 system. It is non-radiometric automated system. It can differentiate TB from non-TB complex from non-TB mycobacteria. Also, we can use to do drug susceptibility test in cases of drug resistance. The average time of detection less than the solid media. It takes about 12 days. Radiology, there are no specific radiological patterns suggestive of TB, but it may help in the view of the clinical finding. Radiology may show, may localize abnormality, it is unilateral or bilateral, may help in smear negative pulmonary tuberculosis, may help to diagnose in cases of extrapulmonary TB. Also, we can use it at the end of the course to evaluate the responseless therapy and diagnose suspected complication. Gene expert, as our professors said, it helped to detect Mycobacterium tuberculosis and rifampicin resistant. The result appear as early as 2 hours in the lab, and it will be available in the health facilities within 48 hours. Gene expert is indicated in all new cases presenting with delayed conversion after 2 months of therapy, negative pulmonary TB, symptomatic patient contacted to an MDR case, HIV positive cases, or extrapulmonary tuberculosis. We can send the tissues and the body fluids to gene expert analysis. In the previously treated cases, if the case presenting with treatment failure, you can do from the start gene expert. But if relapse was suspected or defaulter, we can do smear microscopy. If it is negative, give non-specific treatment. If it is positive, do gene expert. Histopathological examination, tissue is the issue. Its role mainly in extrapulmonary tuberculosis. We can take a lymph node biopsy, pleural fluid samples, skin biopsy, endometrial biopsy, because TB sure diagnosis is depend on the visualization of mycobacteria on smear culture or caseating granuloma in tissue biopsy. What about the treatment? Treatment will be done after direct smear microscopy for acid-fast bacilli. If we have 2 or 3 positive samples, we can start the treatment. One sample is positive. If the clinical finding and the radiological finding are highly suggestive of tuberculosis, we can start the treatment on the clinical judgment and treat the case as a TB case. If you are not suspecting surely that this is a case of tuberculosis, repeat direct smear microscopy for acid-fast bacilli. Negative case, you should be sure from the diagnosis, but positive cases, you can start the treatment. If the 3 samples are negative and you are suspecting a tuberculosis, do gene expert. If positive, start the treatment. If negative, exclude other causes mimicking tuberculosis. And this is the categories mentioned by Professor Wagdi and Professor Ayman Salim. All TB cases should start a 6 months course, and the initiation phase 2 months 4 drugs, and the continuation phase 4 months 2 drugs. The other category include the relapse, treatment and failure, and the defaulters. It includes 3 months intensive phase. The first 2 months start 5 drugs: rifampicin, INH, pyrazinamide, isambutol, and streptomycin. Then 1 month 4 drugs, all except streptomycin, and the continuation phase include 5 months 3 drugs. The total duration will be 8 months. All anti-tuberculous drugs should be given as a 1 single daily dose to obtain the synergistic effect of all drugs, and the most drugs should be given on empty fasting stomach to help the maximum action of the drug. What about the special situation in women? Treatment of tuberculosis during pregnancy is much more safer than to left the mother and the fetus without treatment, because the complication of tuberculosis during pregnancy is much more hazardous to the fetus and the woman. All TB drugs are mostly safe during pregnancy except streptomycin. Isoniazid, rifampicin, isambutol, pyrazinamide, all are class C. But clinical experience with these drugs suggests safety in pregnant women. Streptomycin, class D. What about LTBI in pregnancy? The women with LTBI have 10% lifetime risk of reactivation of tuberculosis, but with the presence of HIV, the risk increased to be 5 to 10% per year without antiretroviral therapy and 2% on antiretroviral therapy. Treatment of LTBI in pregnant women will depend on, is this a low burden countries or high burden country? And it will also depend on the HIV status. Is the pregnant woman HIV positive or HIV negative? In low burden countries, we can give interrupted course or continuous course of INH. The interrupted course will include INH 900 milligram twice weekly per 9 months, and the continuous course include isoniazid 300 milligram per day for 6 to 9 months. In the high burden countries, we should give continuous course to avoid the resistance with the interrupted course. In HIV negative cases, in the low burden countries, we can postpone the treatment to 2 to 3 months after delivery, because during a pregnancy, cytochrome B 450 will be activated by the pregnancy, and this will increase the hazard and the hepatic toxicity from INH treatment. But in HIV negative cases, in high burden country, no recommendation to treat LTBI during pregnancy. HIV positive cases, in low burden countries, start immediate treatment for IGRA or tuberculin skin test positive cases. In high burden countries, immediate treatment for HIV positive cases without active tuberculosis but have LTBI for LTBI. Breastfeeding. A pregnant breastfeeding woman should continue her full course of anti-tuberculous treatment during breastfeeding. Even if she had tuberculous mastitis, she can continue breastfeeding from the unaffected breast. If the mother is infectious, the child should receive prophylactic INH 10 mg per kg per day for 6 months and continue breastfeeding. BCG vaccination should be postponed until the end of INH therapy, because INH will counteract the effect of the BCG vaccine. Also, BCG vaccine should not be recommended to given in HIV-infected child, because this carries the risk of dissemination of BCG vaccination to be a BCG disease. What about contraceptive pill? Rifampicin reduces the effectiveness of the contraceptive pill. So the woman should be advised to use one of two methods. Either oral contraceptive pill containing high doses of estrogen, or to use another non-hormonal method of contraception. MDR tuberculosis, all the second-line drugs which used for MDR treatment are class C, but they carry a very high risk of fetal toxicity. Some of them cause ototoxicity, nephrotoxicity, and some of them are secreted in the breast milk. So they should be avoided, but if the case is serious and the clinical judgment recommended to start the treatment, you can start the treatment in spite of these toxic symptoms to the fetus. TB-HIV co-infection, rifabutin can be substituted for rifampin in patients with HIV, because rifampin decreases the proteases inhibitor level by 80%. Also, rifampin reduces non-nucleoside reverse transcriptase concentration. The dose of an integrase inhibitor should be doubled with rifampin. So rifampin decreases the effectiveness of antiretroviral therapy, so this may prevent proper treatment of HIV. So rifabutin can substitute it for rifampin in patients with TB-HIV co-infection. Conclusion: in most countries, TB notification is twice as high in men as in women. Although socioeconomic and cultural factors are leading barrier to under-notification in women, particularly in developing countries, biological mechanisms may actually account for these differences between male and female susceptibility, especially iron deficiency and the estrogen hormone. TB is difficult to diagnose in pregnancy, so it is important to screen, diagnose, and treat TB early to ensure favorable outcome of pregnancy. Thank you.
Thank you. شكرا جزيلا دكتورة صباح. Now may I call دكتورة سمرة. We'll talk about interventional bronchoscopy in thoracic tuberculosis. Dr. Semra, we have time for prayer. So can we limit it for 15 minutes, just 15 minutes? Okay, because we have short of time. Okay, thank you.
Dear colleagues, dear friends, as you all know, As you all know, the overall diagnostic yield of bronchoscopy is around 77%, but it may range from 11 to 96%, but I'm talking in general. This diagnostic yield depends on what type of method you are using and in which form of tuberculosis. Otherwise, you may not be successful. Just an example, in miliary tuberculosis, you have to use transbronchial biopsy, maybe combine it with bronchial aspiration, but the highest diagnostic yield can be achieved by transbronchial biopsy. Let's come to the interventional methods. Let's mention about EBUS-TBNA. Whether it's radial or convex probe EBUS-TBNA, it has been shown, although in limited literature, EBUS-TBNA has high diagnostic yield in TB lymphadenitis and also in pulmonary TB, like tuberculoma adjacent to the airway. The sensitivity, again, changes between 65 to 94%. Negative predictive value can be very low, although it says 11 to 75%. But this method can be used in diagnosing tuberculous lymphadenitis or any tuberculous lesion adjacent to the airway. There's a nice study, I think it's the best study till now, by Navani and colleagues, published in Thorax in 2011. The conclusion of the study is when you get EBUS-TBNA samples, get pathological samples, but both cytological smears and cell blocks for pathological diagnosis, but also send some of the material to microbiological assessment, because you may lose some of the cases if you don't send your specimen for microbiological analysis. And they could also determine in their study drug-resistant TB by using EBUS-TBNA. So don't forget to send the specimen to culture also. Also, you can ask for PCR analysis. When we compare EBUS-TBNA with conventional TBNA, indeed, the results are comparable if both specimens are sent to microbiology and pathology. As you can see here, the first picture is showing the microbiological specimen, and the other is granuloма with necrosis. This is true for both methods. So EBUS-TBNA is not much better than conventional TBNA. Just know how to do it and what to send where. Another thing, we are in an era that we should be careful with cost effectiveness. I mean, don't do all the time EBUS-TBNA in a case that is suspected of tuberculosis. You can use conventional methods, conventional TBNA and other methods. And if you do first the conventional methods, get diagnosis, it's okay. If you cannot get the diagnosis, still suspicious, you can use EBUS-TBNA. And this is shown that when you combine conventional methods and then in negative ones use EBUS-TBNA, it's more cost effective and the diagnostic yield increases. This is a table that is a little bit busy, but shows the therapeutic interventional bronchoscopy in tuberculosis. What are the main complications of tuberculosis that we can treat by using interventional bronchoscopy? Tracheobronchial stenosis, bronchopleural fistula, bronchoesophageal fistula, and hemoptysis. Tracheobronchial stenosis can be treated by using mechanical dilatation, balloon dilatation, hot treatments, cryotherapy, stenting, and also we can use radial probe EBUS to assess the airway wall. It's not for treating, but it helps the treatment, the interventional treatment decision. There are not very nice reviews or meta-analysis about this, but I tried to gather different studies, and in dilatation, the success rate is 30 to 40%, but there is high recurrence in tracheal stenosis or airway stenosis. The procedures should be repeated, or stenting should be analyzed 2 years later. So stent stays 2 years, but at the end of 2 years, you remove the stent and see whether the airway is good. I will mention more in detail later, but these treatments can be combined to get better success. Bronchopleural fistula can be treated by using fibrin glue, hemoclipping, gelatinous sponge, cyanoacrylate. These are difficult cases, and if the fistula is visualized, you use these. If it's distal, you can use valves, spigots, stents, coils, atrial septostomy catheter that cardiothoracic surgeons use. With valves and spigots, the success rate looks like 70%. Bronchopleural fistula, you can use again fibrin glue, similar material, cyanoacrylate. For hemoptysis, it depends whether the hemoptysis area is visible with bronchoscope. Whether it's not visible or visible, we will mention about it later. But you can use saline, adrenaline, electrocautery, argoplasma, coagulation, Fogarty balloon catheter, or double lumen tube. Let's come to stenosis. Which type of tuberculosis creates or leads to stenosis? It is endobronchial tuberculosis. So in a case of endobronchial tuberculosis, you have to be quick and careful because there is a potential for airway stenosis, and you have to diagnose early, maybe do some interventional treatments while the anti-TB treatment is going on. Don't wait till complete fibrosis occurs at the end of 6 months. What are the reasons for stenosis? It's not very well defined, but immune status of the patient can cause it. And there are some studies on TGF-beta that increases in bronchial washings, also decreases in serum, in the serum. And there is also upregulation of matrix metalloproteinase activity. And there are different types of endobronchial tuberculosis. This one is non-specific bronchitis, and it is seen that it has good prognosis regarding stenosis. You don't get much stenosis at the end when you treat this type of endobronchial tuberculosis. Hyperemia and swelling, this type has a bad prognosis, and stenosis can occur in up to 64% of the cases. When it's granular like this, the prognosis is good, but of course stenosis can occur in about 18% of the cases. When it is active caseating, as in the picture, prognosis is again not good because there is a lot of granulation tissue occurring, and that leads to stenosis. Ulcerative has good prognosis. Some of these cases can go to stenosis. Tumorous type, it's not predictable in this one whether stenosis will occur or not, but sometimes it is with good prognosis. Fibrostenotic, from the beginning, the prognosis is bad. Maybe it's late case, or I don't know, the immune system. So we have to know these appearances, bronchoscopic appearances, and act quickly, not too late, while the treatment of TB is going on. What is the critical thing? The granulation tissue. All of these endobronchial TB forms can turn into each other, but at the end, what is causing fibrostenosis in the airway is granulation tissue. We are trying to, interact this granulation tissue. Persistent stenosis has some risk factors, and two main risk factors are the length of involved airway and decrease in FEV1. There are studies done. These two factors show that this patient will have stenosis. Degree of bronchial stenosis or tracheal stenosis is important, but also the functional activity of the patient important. If there is a sedentary patient having, say, 50% obstruction in the airway, probably he won't complain about dyspnea, but a construction worker who has maybe 33% tracheal stenosis will complain. It depends on the activity of the patient too. So we do our interventional procedures according to the to these two factors, degree of bronchial or airway stenosis and functional activity and the symptomatic position or status of the patient. And when the stenosis is above 50%, like 67 to 100%, is called severe stenosis. Treatment goals, of course, anti-TB treatment is in the first case, but we have to act early in diagnosis and treatment and know the cases that are risky for tracheal stenosis or bronchial stenosis. Treatment of the established stenosis is done, but try to treat before the stenosis is occurring. While it's in the inflammation state, try to treat. And we have to maintain the airway patency, and we have to marry the patient and long-term follow-up. What do we do as workup for management of airway stenosis in TB? Of course, we have to have CT, white light bronchoscopy, and also radial probe EBUS is very helpful to see whether the cartilage or the airway wall is involved. Although it's not used very frequently, in the studies done by Miyazawa and some American colleagues, it is very well emphasized that radial probe EBUS shows whether the cartilage or the airway wall is involved. And then you do your treatments according to these quantitative and qualitative evaluations on the stenosis. Virtual bronchoscopy can be used to assess lumen size and distal lesions, to follow up degree of stenosis, and to follow up patients unfit for bronchoscopy. Now let's come to the treatments. There are some studies or case series injecting steroid into submucosal area when there is endobronchial tuberculosis using conventional TBNA needle. And they report good results, not maybe in all of them, but it's a palliative procedure. Others, cryotherapy, as we do in other diseases, we can use cryotherapy for granular lesions when we are diagnosing the patient. We can get rid of the granular lesions. If there is so much stenosis, we can also dilate after the cryotherapy using balloon. And we have to follow up the patient periodically. Argon plasma coagulation can be used in bleeding lesions, but also in tumorous lesions. It's just coagulation mode. We do not carbonize the lesion, we coagulate. Electrocautery can be used for stenotic lesions, not to get rid of the lesion, but if there is a web-like stenosis, you can have 3 cuts in the web-like mucosal lesion, and then you can dilate by rigid bronchoscope or by using balloon dilatation. Laser can be used as electrocautery is used to get rid of the cicatricial stenosis, granulation tissue. Again, we are coagulating, we are not carbonizing, and it gives immediate relief. We can combine mechanical dilatation with debulking. Why? It decreases the number of complications and increases the effectiveness. So we can use the bevel of the rigid bronchoscope to dilate the stenosis, but always do balloon dilatation first, then the rigid bronchoscope dilatation. They say less complication occurs in this way. Here you see the balloon dilatation by using French Fogarty balloon catheter. Sometimes restenosis occurs after the dilatation. This is typical in TB. You have to repeat the procedure. Stent insertion is another option. Covered expandable metallic stents are used, but they cause granulation tissue. There can be stent migration, too much coughing. But in long time, because you keep the stent in 2 years, there is a metal fatigue, and then the metal is broken, go into the mucosa. It's a disaster. So try to use silicone stents, not metallic stents in TB as in other benign cases. Before stent insertion, we can dilate and then put stent if it's necessary. Again, silicone stent has some complications like migration, mucostasis, granulation. Even during this stent period for 2 years, if there are some granulation tissues beside the stent, we can get rid of them by using ablative treatments. And we can get rid of granulation tissue by using topical mitomycin C, which is an immunosuppressive drug, as we use corticosteroid to get rid of the granulation tissue.
Dr. Simra,
Yeah, it's finishing.
Okay.
When we are removing the stent, we can again use radial probe to see the cartilage status. They say when there is air pockets around the stent, in between stent and the airway, if it's more than 2 centimeters, there is higher success in getting an open airway. And at the end of the 2 year, if there is still stenosis, you should suspect bronchomalacia. Bronchopleural fistula can be treated, as in this case, by using cyanocrylate. This is a bronchoesophageal fistula. Hemoptysis occurs in bronchiectasis, fungus pole, broncholithiasis, destroyed lung, vascular erosion by necrosis. Of course, you have to have thoracic CT and then do bronchoscopy. The management depends on whether the bleeding area is visible or not. If it's visible, you can use electrocautery, APC laser. If the area is not visible, you use this algorithm. Since we don't have much time,
we don't have time
depending on the visibility, I'm finishing, you can use different methods. Thank you for your attention.
Thank you.
Thank you very much, Professor Simra. I think we have now the time for prayer, جمعة prayer, and هنرجع تاني إن شاء الله على الساعة 1 في جلسة عن الساركيدوز إن شاء الله.